Good afternoon, everyone. Center of Excellence in HIV Care at PGIMER Chandigarh welcomes all the participants for today's RDLS session. Today's topic is Basics of Chest Radiology among PLHIV, and the speaker is Dr. Shankar Naidu. Dr. Shankar Naidu sir is currently working as the Deputy Program Director with the Center of Excellence at Postgraduate Institute of Medical Education and Research, that is PGIMER Chandigarh. We welcome you, sir, for today's session and request you to start the session.
Yeah, thank you, Mr. Tha, and good afternoon, everyone. So, in today's session, we are going to actually, in a way, revise most of the things that we all of us know, the basics of chest radiography, and just be speaking about how it is important in our day-to-day practice in our PG centers. So, chest radiography is one of the major easily available and cheaper investigation, but it is a cornerstone for diagnostic evaluation for any patient who is presenting with respiratory symptoms. And it is even more important for our group of patients, that is PLHIV. Because each of the HIV-related opportunistic infections and neoplasms, they have a characteristic radiographic presentation. Obtaining a radiograph at the time of presentation to us with respiratory symptoms narrows down the diagnostic possibilities and suggests the most possible etiology and further management approach. So basics of the basic principle of chest radiography is that a beam of X-ray photons is put on the subject, and the rays are captured by the X-ray film, and depending on the intervening structures which are present between the photon beam and the X-ray film, there would be appearance of the various images on the X-ray film. So some structures like air, which are usually not, they won't absorb the X-ray photons, so they will appear the blackest of the X-ray film. And structures like bone and metal and other contrast materials that we inject will absorb the X-ray photons, so they appear as the white structures on the X-ray film. So based on the and this absorption depends on the tissue density which is there in the patient. So based on this interface, there will be images which are being formed on the X-ray film, and we see those films, and then we interpret the findings. So this is like we see because of the interface between the various structures. So there is a difference in the absorption rates of these X-ray photons. So the different structures will appear in different densities. So that is why we are able to visualize the various structures in the thoracic cavity. So another important finding or feature that we need to remember is the Silhouette sign, where there is a loss of expected interface. Like for example, here is the hard border. So any opacity which is lying in this lower zone adjacent to the hard border would mask this right hard border. So there would be silhouetting of this border. So this is important to remember because many a times silhouetting might indicate some pathologies, and sometimes it might actually mask few things which are there in the X-ray. So like here, there is a consolidation patch over here, which is masking the diaphragmatic border. So we need to identify this silhouetting so that we can correctly interpret the X-ray. So there are some general principles before we start interpreting the X-ray findings. So the most important thing is always confirm that the X-ray that you're reading is for the patient that you have ordered for. So identification of the patient details is very much essential, especially in busy areas. Like if we are having a lot of patient overload, then it is always important because wrong interpretation would result in wrong prescription. So always check for the patient identification details. Then you need to know the view of the X-ray. There mainly three views are there. That is the posterior, anterior, which we commonly do for identifying the parenchymal lesions. Then anterior posterior is mainly used for identifying the bony structures in the thoracic cavity. like fractured ribs and other bony structures. Then sometimes in special occasions, we might require a lateral view to exactly delineate the position of the pathology that we are seeing. So after that, what you need to remember is this mnemonic, right? We have to see for the rotation. R stands for rotation, I stands for the inspiratory status, then P stands for the position of the patient, and E stands for the exposure. So you always the X-ray film has to be centrally placed. That is, there should not be any rotation of the film. Then ideally we should have an inspiratory film, X-ray taken in the deep inspiration, because expiratory films would mask few of the findings. Then for interpreting the lung parenchymal changes, we always prefer the X-ray to be done in an erect position. However, the patient is very sick and admitted, and especially the patients who are intubated, then supine position is sometimes we come across. So we need to know how the changes are there in between erect and supine position so that we correctly interpret the findings. Then exposure is very important because under exposure or overexposure will mask many findings. So which I'll be showing in the subsequent slides of why the exposure is very much important. And the next important point is interpret the X-ray in conjunction with the clinical features. So the patient, you should always correlate between the clinical findings and the X-ray findings so that a correct diagnosis is established. And sometimes the patients might, especially patients who are having a chronic disease, they might have previous X-rays, and if they are available, it is always a good habit that we compare the changes that are happening with respect to the previous X-rays. So I'll be showing few X-ray films and then showing you the importance of this things that I've told in the previous slide. So view and position like this. This is the erect PA view. So this is what we usually order for when we are thinking of looking for the lung parenchymal disease. So the ideal position view is the posterior anterior view, and this is how it should look. So the same patient, if the AP view is taken, so you can see this is both of them are from the same patient taken at the same time. One is PA view, the other is AP view. So as you can see here, the heart appears to be enlarged in the AP view compared to the normal heart size in the PA view. And also the mediastinum appears to be slightly broader compared to the actual size of the mediastinum. So that is the problem with interpreting the AP view chest radiograph, because the heart and the mediastinum are slightly on the anterior aspect of the thoracic cavity. So when we take an AP view, they appear to be more bigger in size compared to the PA view. So always prefer to get a PA view chest X-ray. However, in patients who are sick and on ventilator, sometimes we might have supine view also with the AP view. But remember that these structures might slightly appear enlarged. And also the level of the diaphragm is also slightly higher in the supine position compared to the erect position. So the next thing that you need to notice is the rotation of the film. So this is a well placed X-ray imaging done. So as you can see, these are the spinous processes. They have to be equidistant from both the clavicular margins. So if this is there, then that means the X-ray is correctly positioned. The patient is correctly positioned. The X-ray beam are in the right angle. But as you can see here, there is a rotation of the film. So here, when there is a rotation, sometimes the mediastinum and other structures might appear slightly enlarged. So we should always see whether the X-ray is correctly placed or not. And regarding the importance of inspiration, this is an ideal taken at the end of deep inspiration. So if there is a proper taken at the proper end inspiratory phase, then you ideally will make out about 10th rib crossing the mid of the diaphragm. This is the posterior aspect. If you look at the anterior aspect of the ribs, then approximately 1, 2, 3, 4, fourth or fifth rib should be crossing the diaphragm. So this would indicate that adequately the lungs have been expanded. So then it would become easier for us to interpret the various changes. So this X-ray again taken from the same patient at the same time. One is a deep inspiratory film, while one is an expiratory film. So as you can see here, the lung volumes appear to be reduced in the expiratory film, and that is expected. And sometimes you can see that there are a lot of nodular kind of structures in the expiratory film, which are actually not there when it is taken in the deep inspiratory film. So, this, if we are interpreting in an expiratory film, sometimes we might overinterpret these changes which are actually not present in the patient. So that is why it is important to obtain an X-ray in deep inspiratory phase. And also you can make out the heart shadow as well, where you can see this in the expiratory film. It appears to be slightly enlarged compared to the deep inspiration. So regarding the exposure, these are various examples. Like this is an underexposed film, this is an overexposed film. And this is ideally what we want. So as you can make out here that over penetrated films are usually you will not be able to make out much of the structures because the energy of the X-ray beam that has been given is so high that you are unable to differentiate the different structures which are there in the thoracic cavity. So most of the structures will appear as dark black in color. So you are not able to identify the parenchymal changes or for that matter even the bony changes. So overexposed film. And how do you identify overexposed film? Whenever you see the vertebrae which are very clearly delineated, it is always indicated that the chest X-ray is overexposed. Whereas if you compare with an underexposed film, here you can see that you are unable to make out any outline in the vertebrae. So this would indicate that this is an underexposed film. So when there is an underexposed film, then you will not be able to again identify the various structures because the X-ray photons are not actually uh, having energy to traverse all the layers of the body cavity. So some structures might not actually appear on the X-ray film. So this is how an ideally exposed film should look like. So you should be just about to make out the vertebral border in the mid-thoracic cavity. So if you are able to identify this vertebral, it should not be as clear as seen in overexposed film, but you should be just able to know that there are vertebrae and how the outlines of this vertebrae. Then that indicates that it is an correctly exposed film. So now that we have seen that we have taken the film and we have checked the basic things that are common for most of the patients that we need to see, the next step is to read the chest radiograph. So always interpret the chest radiograph systematically. So there is a mnemonic. There are various ways to interpret a chest X-ray. Some say go from inside to outside, like inner structures starting from trachea to the outer structures like the rib cage and the extrathoracic soft tissues. Some say start from outside and read inside, go inside, like starting from the extrathoracic soft tissue to the central airways. So both the ways you can practice, but you need to remember that whichever way you're practicing, you should always cover all the structures that are there in the X-ray. So this is one mnemonic, easy to remember, I felt, so that is why I'm showing it here. A, B, C, D, E, and F. So A stands for airway, B stands for bones, C stands for cardiac structures, and D stands for diaphragm. Then E stands for effusions or the pleural space. Then F stands for the lung fields. So if you remember this mnemonic A, B, C, D, E, and F, then you can go in this way so that you will never miss any of the structures that you need to check for. So in the next few slides, we'll discuss about the various structures in this order. So first coming to the airway, you need to see for the tracheal position as this has been highlighted in the red arrows. So this is the trachea, the air shadow within the trachea. And as you go lower down, this is where the bifurcation of the trachea happens. So I hope you can see the left main bronchus going here and here the right main bronchus. So the junction where these two are dividing is the level of the carina. So we need to see whether all these things are clearly visible or not, whether there is any structure. Sometimes patient might be intubated, so they might have an endotracheal tube within the trachea. So you need to, if there is an endotracheal tube, you have to see whether that is in the right position or not, whether it is at the right level or not. Sometimes, many a times, the endotracheal tube might go into the right bronchus, leading on to collapse of the left bronchus. So all these things we need to be always uh, uh, clear whether the tracheal endotracheal tube is in right position or not. Sometimes there might be abrupt cutoff in many of the bronchus because of maybe some infections or growth or maybe some mucus plug. So all these things we need to check in the air. So these are examples of some of the X-rays where there is a deviation of the airway. As you can see here, the trachea is deviated to the left side. This is mainly because there is a compression from the right side. So there is a large pneumothorax which is putting pressure over the trachea and pushing it into onto the opposite side. Again, similarly, large effusions can again push the trachea to the opposite side. Or if there is any mass lesions in the upper mediastinum or the paratracheal space, like in this X-ray, the trachea can be pushed to the opposite side. Sometimes the trachea may be pulled towards the same side, like in this patient, in this X-ray, there is a lung collapse. So this lung collapse is pulling the trachea towards the right side. So we need to interpret the tracheal shift based on the pathology that is underlying in the lung. So the next structure we need to look after is the bones. For us, we might not actually understand about bones, but always we should at least screen them. So these are the various structures. This is the clavicle. These are the ribs. This is the anterior aspect of the rib, and this is the posterior aspect of the rib. Then these are the vertebrae, and this is the scapula. So these are to be identified, and all the margins have to be seen. If there is any discontinuity in any of the ribs or any other clavicular fracture or any presence of cervical ribs can also be identified once we look for the bones. Then the third structure is the cardiac. C stands for the cardiac structure. So we need to look after the borders of the heart borders, whether they are in position or if there is any enlargement or not. Other than the heart borders, then this is the aortic knuckle, this is the pulmonary artery area. So this is the aortopulmonary window. So all of these structures have to be identified because any pathology in these structures can also alter this morphology. So then D stands for the diaphragm. Then we need to look for the margins of the diaphragm. The right diaphragm would be slightly at a higher position than the left because there is a push from the liver from here. So the right diaphragm is slightly 1 or 2 costal spaces higher than the left diaphragm. And it has to be a uniform concave kind of line. If there is any abnormality or the diaphragm flattens, then that indicates that there is some pathology in the diaphragm. And apart from diaphragm, you need to look at the subdiaphragmatic place, especially on the left side for the gastric gas shadow. And also the costophrenic angles have to be seen. So costophrenic angles, that is the between the diaphragm and the pleural surface. So these have to be very acute in angle and they should be tapering down like this in a normal individual. So if there is any abnormality, sometimes when there is a mild pleural effusion, these might be the earliest changes that might appear where the costophrenic angle is obliterated. So we should always give importance to checking the costophrenic angles for early detection of effusions. So effusions, as effusions or pleural disease, it could be accumulation of fluid, or sometimes that might be just pleural thickening, or there may be some air in the pleural cavity or calcification of the pleural cavity. So we need to identify all these structures. So next few slides, I'll be showing some examples of the X-rays where we can see. So here, as you can see, this is a massive right-sided pleural effusion where you can see that there is a lot of fluid accumulated in this right pleural cavity, and that is actually covering the nearly 2/3 of the right thoracic cavity and probably compressing and collapsing the right lower lobe and middle lobe. So this is what I was saying, the blunting of the CP angle, where this might be the earliest sign of a pleural effusion. So it is very easy to identify pleural effusion when this much of fluid is accumulated here, but it is very important to identify minimal pleural effusion so that appropriate investigations are being done. So picking up this early blunting of CP angle is very important in some of the patients. And sometimes patients can have bilateral pleural effusion as well, where as seen in this X-ray. So sometimes the effusions can be very localized. This is one effusion where there is accumulation within the horizontal fissure in the right lung. So this might actually look like a mass or consolidation, but this is actually fluid in the fissure, major fissure on the right lung. So sometimes there can be loculated effusions, like you can see that there is a effusion which is very much circumscribed to one location. There might not be CP angle blunting, but it might be there somewhere else. So all loculated effusions have to be identified. And also, this is what this is actually in the pericardial fluid, where there is a globular enlargement of the heart. So always see for effusions in the pericardial cavity as well. So sometimes, like tuberculosis patients, they can have pericardial effusion. So it is important to identify pericardial effusion on X-ray as well. This would appear like cardiomegaly, where you can see that the diameter of the heart is more than 1/2 of the entire thoracic cavity. So sometimes patients can also have pneumothorax. So this is an example of right pneumothorax, where you can see that there are no bronchovascular markings beyond this margin. So there is a collapse of the lung because of accumulation of air in the pleural cavity. So you can make out this bronchovascular markings, which you can see the reticular kind of pattern, which is extending only up till this level. So beyond this, this is all air in the pleural cavity. So this is an example of a pneumothorax. Then sometimes there can be combination of fluid. This is a hydropneumothorax, where you can see that there is a horizontal level of air below which there is some fluid. So this would indicate that there is a hydropneumothorax in this patient. And many a times, if there is a large pneumothorax, the corresponding lung will also collapse. So here there is a complete collapse of the right lung, which is just replaced by this dense shadow. And sometimes there would be some calcification or thickening of the pleural cavity, especially sequelae of the previous infections like tuberculosis. So here you can see that there is white streak in the pleural surface of in the apices. So when CT is done in this patient, it has shown that it is basically a pleural calcification. So this would indicate that this would be a sequelae of the previous infection that this patient might have had. So next, coming to the most important thing, that is the lung fields or the lung parenchymal changes. So this is how we divide the lung zones on the X-ray. On X-ray, we usually say as zones. We don't use the word lobes in X-ray. So upper zone is till the second rib. Then second to fourth rib would be the middle zone, and below the fourth rib would be the lower zone. So whenever we describe findings on an X-ray, we always give with reference to the zones: right upper zone or left upper zone, right middle zone or left lower zone. So that is how we are going to describe, and we should not be using the like right upper lobe cavity based on the X-ray. However, if you want to correlate, then this is how the X-ray findings correlate. So this would be the area of the right upper lobe, and this would be right middle lobe, and the lower down is the right lower lobe, which would be better appreciated in the lateral view. So anteriorly, what you can appreciate is mainly the upper lobe and the middle lobe on the right side. And once we have suspecting lower lobe pathology, it is better to get a lateral X-ray so that we are much more clear in interpreting the findings. And similarly, on the left side, this is the left upper lobe area and left lower lobe is in the lower half of the thoracic cavity and better appreciated again on the lateral aspect, lateral view of the X-ray. So what are the things that we come across in lung parenchyma or the lung fields? The most important thing is obviously the consolidation or airspace opacity. Consolidation mainly occurs because of filling of the alveoli with various fluids, especially the pus because of infections or blood, or sometimes the malignancies can also result in accumulation of cells within the alveolar space, resulting in consolidation. It may be diffuse or it may be very localized, involving only one segment or maybe one lobe of the lung, or it might involve bilaterally in multiple areas extending from top to bottom. So this distribution is dependent on the sometimes on the organism and also sometimes on the duration at which you are going to assess the patient. And the most characteristic finding in consolidation is the presence of air bronchograms. So this is basically you will be able to delineate the air-filled bronchus surrounded by the opacified alveolar spaces. So basically, this is an example of a consolidation in the right middle zone. So as you can see here, there is some opacity in the right middle zone. So which you can confirm it on the lateral X-ray as well. So this is a dense consolidation involving the right middle zone, which would correspond to the middle lobe of the right lung. Again, here another example of left lower zone consolidation. And once this has been confirmed even on the lateral view as well, where you can see that there is a consolidation in the left lower zone corresponding to the left lower lobe consolidation. So these are examples of focal areas of consolidation, but sometimes there can be very diffuse infiltrates or consolidation patches appearing in both the lung fields. And and as you can see here, this is the air bronchogram sign, where you can delineate the airways. This is the main bronchus, then dividing into the segmental bronchus and further dividing into lower branch bronchuses. So both the side there is a lot of consolidation happening. So these airways are not larger airways are not involved. So they are appearing as black tubular structures. So this is what we call as the air bronchogram sign. If this is present, then it is always indicative of a consolidation. And sometimes consolidation can be very what we say might mask like some other finding. Like here, there is a consolidation in the upper lobe. Right upper lobe, which you can see that there is a delineation by the major fissure here, and there is some consolidation in this area. So sometimes this can also this can be missed when we are not very suspicious about the findings. Then the other changes that can happen are the interstitial opacities. These are diffuse, localized to pulmonary interstitial, that is the alveolar septae, or the connective tissues that support the alveoli. So they appear as lines or reticulations on chest X-ray, and they may be small, well-defined nodules, especially when like the things that we see in miliary pattern. And the differential diagnosis varies from conditions like pulmonary edema to interstitial lung disease, sometimes infections like PCP, tumors which are spreading into the lung by the lymphatic spread, and rarely sarcoidosis can also have this kind of nodular or reticular opacities. So these are the examples of reticular opacities. As you can see, they are appearing like lacy kind of net-like pattern happening here. So as you can see, this is some net-like things and nodular reticular kind of infiltrates that are seen. So these are all indicative of interstitial opacities. So again, other examples in interstitial opacities here, as you can see, this is the miliary pattern, multiple small nodular opacities distributed throughout the lung parenchyma on both the sides. So these are suggestive of miliary pattern. So this is a classical example of pulmonary edema, which we say as the bat wing appearance. So these are like two wings of a bat spreading on both the sides of the chest lung cavity. So this is very much characteristic of conditions like pulmonary edema, or sometimes uh, alveolar hemorrhage can also have this kind of distribution. So radiologically, we'll not be able to differentiate between pulmonary edema versus alveolar hemorrhage. So depending on the given clinical context, we can differentiate between these two. So radiologically, both of them might appear very much similar. So other than the interstitial changes, there may be small nodules or maybe larger masses. So we say nodules when the size is between 0.2 to 3 centimeters in size. They are usually discrete pulmonary parenchymal lesions with the sharply defined borders, and usually they are circular in opacity, whereas masses are larger than 3 centimeters with similar characteristics. So once we make a note of these findings, then we have to see whether they are single in number or multiple in number, what is the size and what is the border, then presence or absence of calcification and their location. So these are examples of some of the nodules and masses. So this is a well-defined mass. As you can see, this is more than 3 centimeters in size, so we are saying it is a mass. Then this is an ill-defined mass where you can see that the borders are not clearly delineated and they are merging into the surrounding lung parenchyma. Then again, this is a mass relatively well defined. Then this is calcification within the lung mass. So we need to see all these findings when there is a presence of lung nodules or lung masses. Then the other important findings that we might come across in our patients would be presence of cavities, especially we are suspecting tuberculosis. So, and maybe sometimes small cysts in patients when we are suspecting presence of pneumocystis infection. So cysts or cavities are abnormal pulmonary parenchymal spaces filled with air and or fluid with a definable wall. So cyst can be either congenital or acquired because of various infections, and cavities are usually caused by tissue necrosis, and they are usually either sequelae to infection or some inflammatory conditions or maybe malignancies. So once there is presence of cavities of this, we should always note the wall thickness, the inner margins of the wall, then presence or absence of air fluid level within the cavity, and also the number and location of these cavities, and which will give us some idea about the underlying etiology. So these are some examples of cavities. As you can see here, there is a right middle zone cavity here, well-defined, relatively thick walled cavity. And in another patient, there is a cavity in the right middle involving both our middle and upper zones. And there is a air fluid level within the cavity, suggesting some connection within the cavity. Probably there is some abscess over here. So in patients with tuberculosis who had been treated in the past, sometimes they can have this fibrocavity kind of changes. There is a lot of fibrosis happening in the upper lobes bilaterally, and some cavities are being noted in both the upper lobes. So this would help us in coming to a different diagnosis of past tuberculosis when we find this kind of X-ray changes. So these are examples of cysts and bullae in the lungs. So as compared to cavities, usually the cyst will have a thinner wall, and they may be single or multiple depending on the underlying etiology. Again, these are multiple bullae in the chest X-ray noted in one of the patients. So what would be the differential diagnosis of cavity? This is a mnemonic, a cavity itself. So C stands for cancer. A stands for autoimmune diseases like GPA. We stopped using the word vagus nowadays, so we call the vagus granulomatosis as granulomatosis with polyangiitis. Then vascular causes like infarction because of various occlusions in the arteries. Then infections like tuberculosis and bacterial abscesses in the lung. Then trauma like laceration can result in cavities. And sometimes in young patients, there may be sequestration or congenital cystic adenomatoid malformation, which might appear like cavities. So this is a mnemonic to identify these structures. So Are there any radiographic features that suggest benign versus malignant diagnosis when we see cavities? There are some soft points. These are not actually absolutely correct in all the patients. So benign cysts usually will have a uniform wall thickness, and they usually have a thinner wall cavity wall, and smooth inner lining. But and benign cavities sometimes, as you can see here, there's a literally thicker wall of the cavity. However, the margins are usually uniform in benign cavities. Whereas malignant cavities, the wall thickness is usually much more than what we expect in the benign causes, and there would be some irregular lining within the in the inner lining of the cavity. So this would indicate that there would be some underlying malignancy as the cause of this cavity. But however, as I told, these are some soft points. This might not always be true. That you need to remember. And many a times the benign cavities can also have thick wall cavities, and also there may be internal irregularities, especially if there is an infection like fungal infections within the cavities. So the inner wall cavity lining can be irregular even in benign cavities. Then the other important structure that we always should look for would be the presence of lymphadenopathy within the thoracic cavity. So uh, we need to see the site and the size of this lymphadenopathy, which might give important clues regarding the underlying pathology. So this is a paratracheal space where we need to see, look for the presence of lymphadenopathy. Then these are the hilar, perihilar regions where when there is a hilar or perihilar lymph node enlargement, you can identify structures here. So in a lateral chest X-ray, you can identify the infrahilar window in this area. This is the area marked for infrahilar window, where you can see lymphadenopathy due to right hilar lymph node enlargement or subcarinal lymph node enlargement. Then this would be the area for the left hilar lymphadenopathy. If there is an opacity in this area, that would indicate a left hilar lymphadenopathy. Then this would be the area for the subcarinal lymph nodes. So if there is a subcarinal lymphadenopathy, the opacities will appear in this particular area. So as you can see here, these are the lymph nodes which are enlarged in the right paratracheal area, and also the bilateral hilar lymphadenopathy. So again here, there is an opacity in the right hilum, so right hilar lymphadenopathy. And here, there is an opacity seen here again corresponding to the right hilum, so right hilar lymphadenopathy. So after this, it is worth to look again for the epices, retrocardiac areas, hilar regions, and below the diaphragm. So just few examples why these areas have to be looked in depth would be like here in this way X-ray. If you on just glancing the X-ray, it appears to be normal, but once we see at a depth, then we can see that there is some abnormality in the left apical area. So a CT has been done and it has been confirmed that there is a mass-like lesion in the left apical area. And so importance of looking in depth in the epices. Then retrocardiac space, again, at the first glance, it looks like a normal X-ray, but once we look at it deeper, observe more closely, there is some abnormality happening in this retrocardiac space. And you can either get a lateral X-ray to exactly delineate the position, or maybe we can do a CT to confirm this consolidation, which is there in the left lower lobe. Again, looking below the diaphragm is again important because many a times the patient can have perforations where you can see gas appearing beneath the diaphragm, or they might have intestinal obstruction resulting in multiple air fluid levels within the bowel lobes. So sometimes these structures might be captured on erect X-ray. So it is important to look for the subdiaphragmatic findings as well. So now that we have seen how to interpret, there are some examples of various findings that we have come across. So focal infiltrates or consolidation, usually we think of bacterial pneumonias or tuberculosis or fungal infections, and rarely other etiologies like pneumocystis and lymphomas can cause focal infiltration. When we find diffuse and multifocal infiltrate, then again bacterial pneumonias can have, tuberculosis can again have. Pneumocystis becomes one important differential when there is a diffuse bilateral infiltrates. Fungal infections again, cryptococcosis, histoplasmosis can have this kind of diffuse infiltrates. Then viral infections like CMV pneumonitis can have diffuse infiltrates, and rarely non-Hodgkin's lymphoma and Kaposi sarcoma can also have diffuse infiltrates. And if you find reticular nodular pattern, then pneumocystis becomes a important differential. And other than that, cryptococcus and Haemophilus influenzae and histoplasmosis and CMV can also have reticular nodular pattern of X-ray findings. Then alveolar pattern, again, the common would be bacterial pneumonia, then tuberculosis, and fungal infections like aspergillosis or cryptococcosis can have alveolar obesities. Then pneumocystis cerevisiae rarely can present with alveolar opacity and non-Hodgkin's lymphoma. Miliary pattern, the most common and what we call the first thing that comes to our mind would be tuberculosis, but always remember that histoplasmosis, coccidioidomycosis, cryptococcosis, and can also have miliary kind of pattern. And sometimes disseminated malignancies can also have miliary pattern on X-ray. Regarding the presence of nodules, again, tuberculosis, fungal infections like aspergillus, then Kaposi sarcoma, non-Hodgkin's lymphoma, bacterial pneumonia rarely can cause nodules, and pneumocystis cerevisiae rarely can cause nodules. Presence of cysts, again, important differential is pneumocystis. Then sometimes cryptococcosis and coccidioidomycosis can also have small cysts. Cavities, the first thing that comes to our mind would be tuberculosis, but certain bacterial infections like Pseudomonas, Staph aureus, and Rhodococcus can also produce cavities on lung X-ray. Then fungal infections like aspergillosis is again an important differential for cavitating lung lesions. Non-tubercular microbacteria like Mycobacterium kansasi, and sometimes malignancies, either primary lung malignancy or a metastasis from distant primary, can also have cavitating lung lesions. Many a times, despite the high suspicion of infection, the chest X-ray might be normal in the initial phase. So when there is a normal X-ray, but still the patient is symptomatic for the respiratory symptoms, always think of a pneumocystis cerevisiae, because many a times normal X-ray might be the most common finding in this patients. Then disseminated cryptococcosis, histoplasmosis, or tuberculosis, where there is more of extra pulmonary involvement. The lung X-ray might be normal. X-ray might not be sensitive enough to pick up the small changes happening in disseminated disease. And sometimes Kaposi sarcoma, which is involving only the trachea, the lung X-ray might just appear to be normal. Then if there is a presence of pleural effusion, always think of tuberculosis, then pneumonic effusions from bacterial infected pneumonias, then Kaposi sarcoma and lymphomas becomes a rare possibilities. Then presence of pneumothorax, not very commonly we come across in our group of patients, but if there is pneumothorax, pneumocystis cerevisiae has to be thought of. Then sometimes staphylococcal infections and tuberculosis rarely can cause pneumothorax. Then mediastinal lymphadenopathy, the Mycobacterium tuberculosis or NTMs can, especially the MAC, can produce mediastinal lymphadenopathy. Cryptococcosis, histoplasmosis, and lymphomas can be the other differentials for lymphadenopathy. So just before concluding, few points on TB HIV co-infection. So this is a natural course of TB. Most of us would have acquired infection in our childhood, this would be the primary focus, which would calcify, which would develop into small focus with regional lymphadenopathy, which is known as the Gons complex. Usually occurs around 3 weeks after acquiring the infection. Then most of the times the patients will get resolved at this level, and there would be calcification of the initial focus. But if there is a spread, that is a primary tuberculosis, progressive tuberculosis, there would be hematogenous spread to other areas. and this is when the tuberculin test becomes reactive. Then, depending on the treatment given or identified or not, it might progress or might get resolved with the treatment. If it resolves on its own, then there would be calcification in the apical region. This is known as the Simon focus. And many a times when there is an immunocompromised state, like in our group of patients with HIV infection, there would be reactivation of this complex resulting in secondary tuberculosis. What we call as a post-primary tuberculosis. So this is the natural course. Majority of the times, the primary tuberculosis heals by calcified granuloma and becomes a latent infection. Only about 5 to 10% will have a progressive primary infection. And among those who are having latent infection, about 5% will have reactivation many years later because of the underlying immunocompromised state. So the risk of TB in HIV patients, we all know, is very high. I don't think I need to go into the details of the prevalence, but as you can see, HIV negative, PPD positive, the risk of TB is about 10%, but HIV positive, PPD positive, the risk is about 60%. And there can be new acquired infection or relapsing infection or reactivation of the previously acquired infection. And the estimated burden of HIV among TB patients is somewhere about 5% in India. So the findings can be usually typical pattern, that is upper lobe involvement with consolidation, fibrosis, and cavitations can be seen in the unilateral or bilateral upper lobes. This is the typical pattern that we come across in other general population as well. So as I said, typical patterns would be space consolidation, cavitations, and endobronchial spread of miliary pattern. And there may be effusions because of the tuberculosis infection. But what we need to remember is the atypical patterns of tuberculosis on X-ray. So atypical we say when the predominant involvement is in the middle zone or the lower zone. So lower lobe involvement is atypical for TB. So in patients who are immunocompromised like PLHIV or receiving other immunosuppressive drugs, the lower lobes might be more involved compared to the upper lobes. So this is an atypical pattern. And also because their immunity is very weak, so there would not be any cavitation formation in patients who are having low CD4 count. So presence of cavitation is very unlikely in advanced HIV. So these are atypical findings of TB. So these are examples of miliary TB, which can happen at any CD4 count. Miliary TB usually indicates hematogenous spread. So as I already said, typically we say upper lobes are commonly involved in 95% of the patients, but in atypical TB presentation, as you can see, the lower lobe involvement is up to say 40%. So again, upper lobe is more commoner, even in atypical presentations, but lower lobe percentage is much higher compared to the typical TB presentation. So whenever you see a lower lobe infiltrate and that turns out to be TB, then always think of an underlying immunocompromised state like HIV positive status or any other immunocompromised condition. Cavitations are common in typical infection, whereas atypical presentation, cavitations are relatively uncommon. Lymphadenopathy is common in both the situations, and effusions may be present in both the situations. So again, reinforcing the same thing, infiltrates lower lobe and multiple site involvement is more in advanced HIV, as is seen in the atypical presentation. So in advanced HIV patients, atypical X-ray findings of TB are more commoner than the typical X-ray findings. So again, these are findings of old healed tuberculosis, calcified granulomas or calcified granuloma with hilar lymph node, that is a Ranke complex, apical pleural thickening or calcification and fibrotic changes in the apicus and volume loss of the lungs. So these are all changes post-infective sequelae of previously either treated or untreated tuberculosis. So I would like to conclude by this important take-home messages. Chest X-ray is a cornerstone in the evaluation of PLHIV with respiratory symptoms, and always ensure that there is a correct view is taken, proper positioning of the patient is done, and proper exposure is there in the X-ray. And we always try to get an inspector film. Interpret the X-ray in conjunction with the clinical features and systematically. The easy way to remember is the ABCDF mnemonic that I have already explained in detail. And atypical findings in TB and PLHIV include lower lobe involvement, more lower lobe involvement, and multiple site involvement, and the absence of cavities. And sometimes normal chest X-ray may be there in the presence of infections. And whenever this kind of situation arises, always think of an underlying pneumocystis jirovecii. So this is because majority of the times in PCP pneumonia, the chest X-ray might be normal. So thank you, and I'll be happy to take up any questions.
Thank you so much, sir. There are no questions in the chat box. We are giving mic access to everyone. In case you have questions, participants are requested to please unmute and ask questions. Any questions from the participants? You can unmute and ask questions. So I don't think there are any questions. Thank you so much for facilitating this session.
Okay, thank you so much.
Thank you, sir. So we'll just quickly run the feedback form. Kiran sir, can we have the feedback form? Thank you. Requesting participants to please fill the feedback poll. There are 5 questions in all. Scroll through the questions and click on the answer of your choice. Please read the last question carefully. We'll wait for another 2 minutes, requesting everyone to attempt the feedback poll. Requesting all the participants to please attempt the feedback poll. Kiran sir, we can end the feedback poll now. Thank you once again, sir. And thank you to all the participants for patient listening. We'll conclude this
Thank you
session.
so much.
Thank you, sir.
Thank you.